लेट हो गया।
Good evening, sir.
Good evening, very good evening.
Good evening, everyone.
So, welcome everyone for this 54th issue of our Enoch DigiConnect webinar series. And today is a landmark day because today we'll be discussing an issue which has been worrying us for last 1.5 years. And still the mystery is unsolved. That is the reason why we kept the topic as COVID-19 and Enigma, interesting insights over a panel discussion. And before starting this program, may I request our President, Dr. Gajendra Kumar sir, to give the welcome address.
Thank you, Sandeep. Well, good evening all.
Good evening.
Welcome to this 54th issue of our regular webinar series. All the participants, all the panelists and speakers. As Dr. Sandeep has mentioned, the discussion of today's topics are very, very important. And it is a fact that it is now almost 1.5 year has passed since the first case of COVID-19 was declared in Wuhan in China. But the total amount of literature which has been generated out of this pandemic in 1.5 year is, I think, more than which has developed in, say, 50 years or 100 years in the medical history. Daily new things are coming up, contradictions are coming up, the myths are coming up. The WhatsApp University, the Google University, the regular Lancets and other, everybody is working very hard, and they are coming out with new things every day. So to clear so many doubts, I think this type of our discussion is going to be in a long way to solve so many problems. So with these few words, I again welcome you all, and I hand over to Dr. Sandeep for further proceeding in the seminar. Thank you.
Thank you, sir. And for today's panel discussion, we have renowned speakers, as we have decided last week only, that certain questions which are to be addressed, and they need to be addressed with an authority by the persons who are treating these particular type of patients, and they had been day in day out dealing with this sort of patients, and they are updated with the latest treatment strategies, investigation strategies, and the vaccination strategies. So the speakers for today is the panelists are Dr. Rakesh Chawla, who is chairman and senior consultant with Department of Respiratory Medicine, Critical Care, Sleep Medicine, Interventional Pulmonology at Saroj Super Specialty Hospital, New Delhi, Jaipur Golden Hospital, New Delhi, and he is also working at Rajiv Gandhi Cancer Institute, New Delhi. With his vast experience, Dr. Chawla is among the most trusted doctors in India in the field of intervention pulmonology, including diagnostic intervention bronchoscopy and medical thoracoscopy, sleep medicine, science of snoring, and sleep apnea. He is very well experienced in tracheal stenting on airway stenting, endobronchial, bronchial electric cautery, APC, cryobiopsy, cryoablation, etc. And he has previously worked with Ministry of Health, KSA, with experience at King Faisal Research Hospital, Riyadh. And he has been trained in sleep medicine from Royal Alfred Hospital, Sydney, Australia, and trained for medical thoracoscopy at Singapore General Hospital, Singapore. Another esteemed panelist is Dr. Aditya Kumar Chawla. He is consultant pulmonology at Saroj Super Specialty Hospital, New Delhi, and Jaipur Golden Hospital, New Delhi. Dr. Chawla, Aditya Kumar Chawla, is a practicing pulmonologist with an experience of 9 years. He is located in Delhi. He is pursued in his MBBS in 212 with from Krishna Institute of Medical Sciences, Karad. He completed his MD in the year 2016 from Royalkhand University, and he is an experienced, skilled, and awarded doctor in this field of specialization. Our other two panelists are our own Dr. Rajiv Kumar Jain, who is our Senior Vice President of AUSD. He is Senior Consultant Health in Indian Railways, New Delhi, 40 years of experience in health and hospital administration, fellow award of Indian Public Health Association, and fellow award of Association of Environmental and Occupational Delhi. And Dr. Rajiv Jain has been guiding us, sir, for last 1.5 years, and even before that, regarding other occupational health related issues. But for last 1.5 years, he has been guiding us regarding what is going on in the at the policy level in the government, and regarding public health management of this COVID-19. So he will be starting with the COVID EPID updates, as he has been giving us and making us aware of the menace which is being caused by this COVID virus. So he will be starting with that, and our fourth speaker is also our live member from Delhi. He is Dr. Puneet Chandna. He is MD, PhD, and consultant molecular oncology and precision medicine author and scientist. He has done his MD in internal medicine and PhD in biophysics, past faculty at WPC Tata Memorial Hospital, and he retains over 2 decades of experience in bioanalytical sphere besides a certified stroke scale specialist from American Heart Association, USA, he continues as a professional member at the American Heart Association and fellow at National Comprehensive Cancer Network. So with this, a great panel we have today, and lot of queries, a lot of unsolved mysteries about this virus uh, are there amongst our colleagues who would like to clarify their doubts regarding treatment, regarding testing strategies, regarding vaccination. So all these panelists, they are master in their field, and we all are the people who work at the grassroots level in our respective industries and try to manage COVID at our workplace amongst our workforce, try to uh, make our management aware what we need to do or our industries so that this particular pandemic can be mitigated in our industries and we can have a continuity of our businesses. So with this, sir, may I request Dr. Rajiv Kumar Jain, sir, to share his screen and he can elaborate the current situation of the COVID in India and abroad so that we can have a broad idea right now what is going on. And then we will come down to all the panelists and our learned participants for a Q&A session on COVID.
Thank you, Dr. Sandeep. As we do every week, the COVID epidemiology, as I've been saying in the past, and I'll repeat that again, COVID-19 is an occupational disease. And this has been now recognized but not only by International Commission on Occupational Health, but the World Health Assembly also has also addressed COVID-19 as an occupational disease. And time will show how important occupation is in the context of COVID-19. So epidemiology and COVID-19 cannot be separated. So going on for the COVID-19 epidemiological updates of today, we will see what has changed. And every day these things change, and things change very fast. We can't even imagine how fast the things change. Next slide, please. We look at the global situation first. This is the situation of the world in the context of regions of the World Health Organization. This is the current COVID-19 dashboard of World Health Organization. Today, globally, there have been 171 million cases of COVID-19. 171 million cases of COVID-19. Can you imagine a disease which was not known till December 19 has affected more than 171 million persons in the world in the last 1 year and 3-4 months. Americas have contributed 68 million, Europe contributed 54 million, Southeast Asia region, of which India is a part, contributed 32 million, Eastern Mediterranean region 10 million, Africa 3 million, and Western Pacific 3 million. Please remember, Africa and Western Pacific, though they may be very low, they are the potential epicenter in the future. If we go to the cases newly reported in the last 24 hours, we will see that largest contribution has been by Americas, mainly Brazil and other countries in South America. While Southeast Asia has now contributed 152,000 cases in the last 24 hours. It has reached the second place. Third is still Europe, 51,000 cases, and 29,000 Eastern Mediterranean, Africa 10,000, Western Pacific 21,000. Next slide, please. We look at the country situation. Top 8 countries are listed. If you look at the countries listed from the top, cases newly reported in last 24 hours, Out of 477,000 cases reported in the world, 132,000 were reported only by India, and 95,000 by Brazil, 35,000 by Argentina, 27,000 by Colombia. United States contributed 15,900, Iran contributed 9,600, Russian Federation contributed 8,947, and Malaysia, a new country in the top 8,200 cases in the last 24 hours. You must notice here that the total number has gone below 150,000 in India in 24 hours. That's a big relief now. Next slide, please. We have a look at the mortality. Out of 10,900 deaths all over the world, 2,700, more than 25% deaths were reported from India. And similar was the case with Brazil, 2,500 deaths. Argentina reported 587 deaths. United States reported 540 deaths. Colombia reported 511. Peru reported 435. Russian Federation 377. And Mexico 306. So what you see, maximum deaths are occurring in Americas. Not in Asia, not in Southeast Asia region. They are occurring in Americas, mainly South America. Brazil, Argentina, Colombia, Peru, and Mexico, all are in South America. Next slide, please. From the world, we come to India now. The broader picture in this slide. Last 24 hours, India reported 1,20,332 new cases, 3,370 deaths, and 20.8 lakh tests yesterday. Remember, the target is to carry out 25 lakh tests per day. That is the commitment by Government of India, that they will scale up testing to 25 lakh per day. 7-day average test positivity rate is still above 5%. It is 6.95%. There are 50,000 active cases, and they're shrinking by 4.9% at the moment. Total, there have been 2.87 crore cases, and 3,44,101 deaths have been reported. And yesterday, there were 33 lakh vaccinations were given, and total vaccination, India has crossed 22 crore 75 lakh vaccination doses in India. Next slide, please. This is the condition with 5 parameters of the COVID infection and 1 parameter of vaccination. First parameter of confirmed cases, Tamil Nadu, Kerala, Karnataka, Maharashtra, Andhra Pradesh, West Bengal, and Odisha are at the top in terms of cases reported in last 24 hours. So mainly now the infection is in South India and Eastern India. But we should not forget the larger picture will come in the column in orange. That is the 7-day average daily growth. As we shall see now, if you look at the column on 7-day average daily growth in percentage in orange color, look at the top 5. Mizoram 1.99, Sikkim 1.75, Manipur 1.66, Meghalaya 1.57, Arunachal 1.29, Tripura 1.28, Assam 1.07, Nagaland 0.77. All are northeastern states in the country, and they are growing at 3 times to 4 times of what Indian average is. Indian average is 0.49%. So a new epicenter for growth of COVID-19 is northeastern part of India. So we must keep our guards on, because it has not gone. It may have receded from Delhi, but it has not gone from India. It has not gone away from Southeast Asia region. If you look at the deaths, even after so many days of Maharashtra having now reported less number of cases, deaths are not coming down. Out of 3,300 deaths reported in last 24 hours, Maharashtra reported 1,377. 1,377 deaths. Tamil Nadu 463 deaths. Karnataka 364 deaths. Uttar Pradesh 136 deaths. Kerala 135. West Bengal 113. So what you see now, deaths continue to be reported by Maharashtra, and southern Indian states of Tamil Nadu, Karnataka, and Kerala are reporting more than 100 deaths every day. But West Bengal is now reporting every day more than 100 deaths. If you look at the tests per million per day, the real observation in the column on green is the picture at the bottom. If you look at the bottom, you find states like West Bengal only 715 tests per million per day. States like Bihar on 909 tests, Madhya Pradesh 936 tests, and Gujarat 1298 tests. These are the states which are not testing enough numbers. Rajasthan is only 636. Nagaland is only 516. So these states are not doing enough testing of their population, even though the daily average growth is high. If you look at the test positivity rate in percentage, 7-day average, Goa is at the top, Nagaland second, Tamil Nadu third, Kerala fourth, Manipur fifth, West Bengal sixth, and Sikkim 7, Meghalaya is 8. So if you look at these states, northeastern states continue to report a very high test positivity rate, and they are not testing enough numbers. West Bengal, even though it is 14.4% test positivity, it is not testing. It is only testing 715 tests per million, while India is testing at 1,520 tests per day. So West Bengal, the test positivity rate may be high, but we do not know the real situation of the spread. So if we do not know, we will not be able to isolate, we will not be able to trace those individuals, we will not be able to institute definitive management early, which would lead to higher death percentages. If you look at the last column on the right in yellow, this is the vaccinated persons with at least one dose in percentage. India has given vaccination at least one dose to 13% of its population, with the highest in Ladakh, Lakshadweep, Dadra and Nagar Haveli, Goa, Himachal Pradesh, Tripura, Andaman Nicobar, Sikkim, Chandigarh, and Delhi. They have all got more than 25% of their population with at least one dose, which is a very good thing. But the negative part is at the bottom. Uttar Pradesh has only vaccinated one dose, 6.83%, Bihar only 7.16%, Jharkhand 9.45%, Tamil Nadu 10%, and Nagaland 10.2%. West Bengal is only 11.8%, while Indian average is 13%. So these are the states which need to ramp up their vaccination on a war footing. Let's go to the other dimension of the infection. Next slide, please. This is an interesting observation which has been published on 3rd of June, where the variant, which was earlier known as Indian variant, which is because it was first discovered from India. Now it is rechristенed as Delta variant, which is B16172. Public Health England has published the confidence in terms of high, low, or high, transmissibility between humans, infection severity, immunity after natural infection, vaccines, and overall assessment. If you look at the assessment rationale, you will find transmissibility appears greater than wild type. In terms of infection severity, there is increased severity in terms of hospitalization risk when compared to alpha variant. Alpha variant, if you remember, was earlier known as UK variant. Immunity after natural infection, experimental evidence of functional evasion of natural immunity, but insufficient epidemiological data, because confidence is low. The evidence needs to be more in terms of establishing that this is true. In terms of vaccines, now there is sufficient evidence in terms of epidemiology and laboratory of reduced vaccine effectiveness. This is now known by 2 vaccines at least, AstraZeneca, Oxford AstraZeneca, which is Covishield in India, and also Pfizer BioNTech. So overall assessment is Delta is predominant, and all analyses find that it has a very substantial growth advantage. The observed high growth rate is most likely to be due to a combination of place-based context, transmissibility, and immune escape. Both English and Scottish analyses continue to support the finding of reduced vaccine effectiveness, which has increased to high confidence. New early data from England and Scotland suggest a possible increased risk of hospitalization compared to alpha. The priority investigations are vaccine effectiveness against hospitalization and transmission, household secondary attack rate corrected for vaccination, characterization of the generation time, viral load, and period of infectivity, and epidemiological studies of reinfection. This becomes the concise, up-to-date data about Delta variant, which is the predominant variant in India. Next slide, please. This is important. Sometimes we do not realize, because the data keeps on piling up, the macro picture is forgotten. May 2021 was the most tragic month for India, as it recorded over 9 million new cases and 120,000 deaths due to coronavirus. Next slide, please. The next fact, the data shows in the first 26 days of May 2021, India accounted for every other new COVID-19 case and every third death due to the infection recorded globally. 50% new cases in the world from India and 33% deaths in May were from India. What escaped everyone's notice is that every second new case and death reported from India in May 2021 was from the rural districts. This means every fourth case reported in the world in May 2021 was from rural India. And that is very important factual epidemiological evidence available in the graph which you are seeing now. Next slide, please. If you look at this condition, predominant rural infection, you add on this of limited infrastructure. This is also a fact. India needs at least 38% more community health centers, which is the first level of health infrastructure where rural population get access to specialist doctors and radiographers. Sub-center shortfall in India 24%, primary health center shortfall is 29%, community health center shortfall is 38%. Shortage of specialist doctors at community health centers is 76%. Shortage of doctors at primary health center is 7%. Shortage of lab technicians at primary health centers and community health centers is 35%. And also shortage of radiographers at community health centers is 56%. These are all facts. Next slide, please. If all that we have told till now were facts, another fact which you must realize, there are wide disparities between states in healthcare coverage and capex spending on health. Average rural population covered by one primary health center in Bihar is 62,000. But in Jharkhand is 97,000. West Bengal it is 68,000. Rajasthan only 27,000. Gujarat 24,000. Karnataka 17,000. And look at Kerala, the best. Kerala is one PHC for 13,000 population coverage. In terms of capital expenditure on public health per person, on the top are Gujarat, Karnataka, Delhi, Madhya Pradesh, and Odisha. In blue, 302 rupees, Karnataka 168, Delhi 155, Madhya Pradesh 148, and Odisha 142. But on the other hand, Andhra Pradesh with only 32, Punjab only 34, Tamil Nadu 61, Rajasthan 65, and Kerala 72. And at the bottom, another revelation, the share of healthcare in total public capital expenditure has declined in recent years. Blue is in by states and red is by center. If you look at the graph from 2010 to 2019, you will observe there is a decline on the right side or static on the right side in blue. So only 2.28% by states and 0.82% by the central government. Next slide, please. Now we go to another dimension, that is the district's micro level data of COVID-19 infection. The All India daily count of new reported coronavirus cases had dipped from a peak of 14,000 on 6 May to about 1,34,000 on Wednesday. However, this drop is not uniform across the country, and there exist pockets that have yet to see their peak. A district-wide analysis shows in the week of 2nd June, about 92% of India's districts reported fewer cases than they did at their peaks of the second wave. The remaining 8% districts saw infections hit new highs in the past week, signaling they are yet to hit their peaks. Tamil Nadu has 8 such districts, while 7 northeastern states have 41 districts. The drop in new cases since the most recent peaks exceeds 75% for nearly half of all districts, indicating a sharp improvement. But for 49 districts, the drop is 50 to 75%. As expected, the longer it has been since the peak, the sharper the drop. Of the 319 districts that had their peak a month or more ago, new cases have shrunk more than 80% in 238 districts. In UP, all 75 districts showed such a sharp decline. State capital Lucknow is down from 40,000 new cases in the third week of April to 637. District of Bihar and Jharkhand also dominate the list. But in all 3 states, undercounting is said to be higher due to the rural burden. Other states where a large percentage of districts have shown a drop are Madhya Pradesh and Rajasthan. Next slide, please. This is the graph showing what I have told you just now. UP, Bihar, MP show biggest drops over second wave peaks. If you look at the graph, the dark red is more than 75% drop, and gray is peak not yet observed. All the Northeast peak is not yet observed. On the left is new confirmed cases in each district in the last 7 days. More than 5,000 is deep red. All deep reds are in the South India. East Godavari is 16,000, Chittoor is 13,700, Coimbatore highest in India. Coimbatore is 25,000, Bangalore 32,000, Malappuram is 22,000. Next slide, please. Look at the death flags. Amid the fall in new cases, deaths remain a concern. For instance, in spite of reporting an across-the-board drop in new cases, UP saw an increase in the weekly toll in 25 of its 75 districts. Kushinagar district in UP reported 90 deaths, 3 times more than a week ago. Similarly, more than half the district in Andhra Pradesh, Kerala, Maharashtra, and Tamil Nadu reported more deaths. However, there is a glimmer of hope. At 22,748, the number of reported deaths in the past week fell marginally for the first time since mid-March. 7 of the 10 worst affected states registered fewer deaths. Maharashtra and Tamil Nadu reported the most. Maharashtra 5410 and Tamil Nadu 3390 deaths respectively. Jharkhand, Gujarat, and Delhi reported sharp declines. Jharkhand reported 101 deaths, about 1/4 of what it reported 2 weeks back. At 172 and 707 deaths respectively, the counts of Gujarat and Delhi were about a third of what they were 2 weeks ago. On the right is the graphical picture. 7 of the 10 worst affected states registered fewer deaths last week. So there is a glimmer of hope. Next slide, please. But look at the other side, vaccine disparities. After a lull, the pace of vaccination in India had picked up, but very selectively. The daily average of 2.6 million doses in the past week was the highest since the third week of April. Kerala, for example, doubled its doses. However, this increase was confined to select states, underscoring inherent supply constraints. As many as 20 of the 36 states and UTs saw a drop in average daily doses on a week-on-week basis. Chhattisgarh saw the highest dip, minus 91%, followed by Punjab, minus 68%, and Bihar minus 63%. Although Himachal Pradesh pace dropped 134% the past week, it still leads on cumulative doses adjusted for population. The hill state has given 333 doses per 1,000 people. It is followed by Delhi, 294, Gujarat, 274, Kerala, 271, and Uttarakhand, 262, all of which have been among the leaders since early April. Uttar Pradesh, 80, and Bihar, 83, bring up the rear and are the only states whose doses per 1,000 people remain below 100. So this is an area of concern. Next slide, please. And if you look at the vaccine global picture, there is a clear Chinese dominance. In the past week, China made significant gains in COVID-19 vaccination, increasing its total dose count by 17%, 17% in 1 week. China has administered 34% of all vaccine doses given worldwide. India remains in the third position on this metric, which is 11% behind the US. But in terms of per capita doses, India stands fifth among the 10 most populous countries. With a weekly increase of 32%, Japan continues to register the fastest ramp up in per capita doses administered. It matched its pace from a week ago, but this is slower than the 42% growth it managed 2 weeks back. India accelerated its pace of vaccination and increased its weekly growth from 5% to 7.4%. As a result, on weekly growth, it climbed from the ninth position in this set to fifth position. In order to improve on this position, India needs more vaccine supply. At present, this is all in different pipelines. And on the right, you can see India is back in the top half on weekly growth in the most populous set. On the left, in the red, are the weekly change in COVID-19 vaccine doses per 100 people. Japan, 32%, China, 20%, Philippines, 15%, Mexico, 12%, and India at 7%. If you look at the cumulative COVID-19 vaccination per 100 people, highest is in US, 88.6, China is 47.4, and 20% is Russia, 15.4 is India. Next slide, please. Another area which needs urgent attention is women are getting left out of India's vaccine drive. A worrying gender gap is opening up in India's vaccination program. In all but 3 states, substantial more men than women have been vaccinated. As on 30th of May, just 871 women had been vaccinated for every 1,000 men. India began its vaccination program with healthcare and frontline workers on 16 January and subsequently expanded it to people over the age of 60 from 1st March and finally to people between the ages of 18 and 44 from 1st of May. As of 30th of May, India had given over 165 million people or under 19% of adult population at least 1 dose of a vaccine. On account of high proportion of women healthcare workers and frontline workers, more women were getting vaccinated than men in the early days of the vaccination campaign. However, since 31st of January, a shrinking share of women is being vaccinated related.
Broad insight of what the COVID situation is right now, epidemiologically, and the way it has affected the life and the livelihoods across the world. So, and today is World Environment Day. So, he has made us remind that we should not play with the nature, Mother Earth also, because it is all because of this playing with the nature. We are getting all these sort of problems and pandemics. And now let us come down to some question and answer session with our esteemed panelists, sir. So, my first question is to Dr. Rakesh Chawla, sir. Sir, for last 1.5 year, we had been learning so much about COVID, and now so much of scientific evidences are there, so much of research is there, so much of public health guidance is there, government policies are there, WHO guidance is there. But still, as a layman, if I am a layman and I am guided by what people say, what scientific community say, they say COVID, most of it, 85% to 90% is only mild and moderate, and you stay at home, take some symptomatic medicines, and you'll get cured. And you will come out of this. And if you have certain parameters deranged, like oxygen saturation suddenly dipping down, or temperature persistently it is more, or you have some raised heart rate or raised respiratory rate, then definitely you need to uh, get hospitalized. These are all ideal things which we tell to the people. But we and India as a whole, we had two waves. In first wave, although this was quite obvious, but in second wave, what happens? People were having faith in this home isolation protocol. They were at home. They were following all sort of home isolation protocol strategies. But when the time came, when their parameters were suddenly deranged, all these public health measures, they were at a failure. No beds were available, oxygen was not available, and it was total collapse of the Indian healthcare infrastructure. So in these circumstances, sir, what would be your advice if suppose we get the third wave, and if we are sitting at home and managing our mild and moderate symptoms, and we are COVID positive, how we should go about it, Dr. Chawla sir?
Thank you, sir. Thank you very much for arranging this question answer session. I'm thankful to the railways and bosses of the railways. I must congratulate Dr. Rajiv Kumar Jain for a beautiful epidemiology picture and telling the actual real facts what is happening in Delhi and across the world. And he has collected a beautiful data which he has shared with us. See, second wave was a disaster. It was what we call it as like a parley. Neither you have seen nor you will see. And we hope the kind of a atmosphere has been created by the government for the fear of the third wave. I think this fear should persist. People should remain afraid. They should stay at home. They should not let their children roam around on the streets. As suggested, these people should not take away their mask and they should keep on washing their hands, and the vaccination program which government of India is trying to escalate at its best. And now that vaccine hesitancy was there in the beginning, people were calling people from the places, please come, and now everybody has understood vaccine is the answer to end the pandemic, and everybody is looking for and is ready to take the vaccine. So what has happened in the second wave was definitely very, very difficult time. As you said, the whole things collapsed, and everywhere it collapsed. Government admits or government wants to save its respect. It is different, but all of us have seen it. Now, my experience, what you want is the mild cases are and asymptomatic cases are where oxygen saturation is maintained. Let me tell you all parameters, let it be CRP, let it be IL-6, let it be D dimer, let it be calcitonin, let it be LDH, let it be serum ferritin, or your LFT and KFT. They are all immaterial if the requirement of oxygen is there or it is not there. If the requirement oxygen is not there, oxygen saturation is above 94, 95, stay comfortable, stay your paracetamol, take the basic medicines what government of India has given you, that you take a course of doxycycline, a course of ivermectin, paracetamol, some any other antibiotic you want to add if there is a source of infection, and be comfortable with a good diet, with a good sunlight. What we call this is summertime, so you can have a baby sunlight of early morning 6 o'clock, all these things. But if your oxygen is between 90 and 93, you are looking for oxygen concentrators, you are looking for the oxygen cylinder. Now this is a very, very dicey decision, because you are not under the watchful eyes of the medical supervision, and it does not take much time to slip it before below 90. So there is a very thin line between moderate and severe. It is up to 90, you label it as a moderate, as WHO criteria, as Ministry of Health Family Welfare criteria, that 90 and 93, 94 remains as a moderate disease. And less than 90, it goes to the severe category. In house, you are not able to differentiate this gap since you don't have a medical care. If you ask me personally, if the patient needs oxygen, please get to the medical care facility where technical people are around, nurses are around to monitor your oxygen, your thing. In house, there are certain things which are not practical. People claim that they can do every hour, but when it slips from moderate to severe, you do not know. So I will definitely say the mild asymptomatic are easily stay at home. There is no issue of panicky. But if oxygen requirement goes up very thin line and you need a hospitalization, and when you are less than 90, you are in the hospital, how things will go, which way thing will go, nobody knows this with this variant. Nobody knew. At the same time, the parameters, as you suggested, the only single parameter which helps you to judge is a CRP, and you want to look at D dimer. These are two important parameters. Rest, people are have stopped all over the world even asking for it, that you need a serum ferritin, you need a D dimer, you need an IL-6. You need IL-6 when you know the patient is very severe. You want to see whether you want to use the medicines which are experimental, or you don't want to use the medicine, because there's, as sir has told, the WhatsApp university has given the knowledge more than what the public can digest. And whatever it is there, they will come, then rest of the things they will read from Google, disturb the medical system and disturb themselves. So my message is that patients with moderate oxygen saturation less than 93%, Indian population, please better to go to the healthcare facility where there is an oxygen available under the watchful eyes. And I am sure now Ministry of Health in all states and Delhi government especially is looking after to address this issue. If the third wave comes, they are prepared and they are predicting the children's. Why children's? Now there is another issue which has started coming, is the vaccination for children has not been given. While Pfizer have started doing from 18 now up to 19, from 12 to 19 years, and Covaxin and Covishield are doing from now from 2 years to 19 years the trials, and soon the data will be there and children should start getting vaccinated. Otherwise, why the virus will start pick and choose the children's. So this is all, I know very difficult to say whether we are having this biological war or whether this is a strain which is affecting our country only, not happening in Bhutan, Burma, Sri Lanka, Pakistan. There is no disaster what we have gone through in April and May, and now things are southward. As Dr. Rajiv Jain has shown, the districts of Tamil Nadu are in the same situation what we were in Delhi, and the districts of Coimbatore, part of Kerala, they are under the same things. But Sri Lanka is joining, nothing is happening there. Or I don't have any knowledge about what is happening in those countries. He may be better telling it. So my answer to layman is that mild asymptomatic, stay at home, moderate to severe, you need oxygen, please report at a healthcare facility. Thank you, sir.
Uh, Thank you, Dr. Rakesh, sir. Now, related question to Dr. Aditya Chawla. Dr. Aditya, you had been treating this. You need to unmute yourself, sir.
Yes, sir.
So, you had been treating these COVID patients, and what we have seen during this second wave, especially, there is a lot of use of corticosteroids, and people have started using corticosteroids at home, and they were not aware that it should not be given during the viral replication phase. It has to be given only when immunodysregulation occurs and when oxygen requirement is there. So everything was in a mess at that time. There was shortage of steroids and other things because of that only. So that one question is regarding this, whether they should take steroids during home isolation period. Second thing, uh, which would you prefer, methylprednisolone or dexamethasone when the patient is admitted? Which will be the preferred corticosteroid in these cases?
Yes, sir. So first of all, I would like to thank the AUH people to have me as an esteemed part of the faculty, part of the esteemed faculty. So going on with your question, sir, first of all, we have to realize कि जो हमारी इंडियन पब्लिक है, द इंडियन पब्लिक, दे आर फर्स्ट ऑफ ऑल दे आर इन द डिनायल फेज कि नहीं, वी डोंट हैव कोविड फर्स्ट ऑफ ऑल. When they are in the viral phase, the starting phase hai, that is the viral phase. At that time they are in a denial ki it's a normal viral, it's not COVID, I have not been outside, I have not gone inside, everything. So they waste their 2 to 3 days in that hodgepodge. Then they go for the COVID testing because the fever is persisting. Then they come out to be positive, so they have already wasted 5 to 6 days when they come to a clinician. So we have to realize that in which phase the patient is. So in viral phase, steroids are not to be given because it is going to prolong the viral phase only, and it is also going to harm the patient. The steroids use is only to be done when the patient is having persistent high grade fever after 7 days of normal treatment that patient is taking at home. That is only hydration, antipyretics, and adequate rest. That's it. So steroids are to be added then. Patients have been starting steroids and antipyretics and even Fabiflu, Favipiravir, everything at home, just on a WhatsApp advice, WhatsApp University, they are reading, and they are starting, and they are spoiling the case when they are arriving in the hospitals. And my advice to the clinicians is not to straight away start steroids in the first phase if the patient is having high grade fever. They're starting antipyretics with steroids, with doxycycline, ivermectin, Limsi, everything they're starting with steroids and with antivirals like Fabiflu, Favipiravir, and everything. Even they are advising remdesivir at home because they are not getting the beds in the hospital. So we have to be judicious with all the use of antibiotics, antivirals, these steroids. Second thing, the steroids dose has to be used in a moderation, 0.5 to 1 milligram per kg body weight of methylprednisolone and zero point 0.1 to zero point 0.2 milligram per kg body weight of dexamethasone. That's it. That is the dose that has been given by the guidelines of Ministry of Health. We were seeing pulse steroids being used, 1 gram of methylprednisolone, 1 gram of methylprednisolone every day for 5 days. Resolution ho raha, but because of that, this black fungus, the mucormycosis, is also come into being, which is not being anywhere else in the other countries. Then we have to see the patient is, when the patient is in a moderate case or a patient is of a severe case and he is in the hospital, patient does not have to be given crystalloids, isotonic crystalloids during hydration. Patient should be given only crystalloids such as normal saline or ringer lactate. And antibiotics are to be prescribed only when there is a suspicion of secondary infection. Then moving on to the investigations that are to be done. CBC, LFT, KFT, the standard investigation can be done every 24 hours. But CRP, IL-6, D-dimer, CRP and IL-6 can be done, CRP and D-dimer can be done after 48 to 72 hours, and IL-6 should be done only if the patient is worsening. HRCT, at starting we were seeing that patients are arriving to us arriving to the clinic or arriving on online consultation with an HRCT in the third day of disease they were having, the third day of fever. So the HRCT should only be advised if the patient is worsening or the patient is having any desaturation, or it should be done after 5 to 6 weeks of the illness has started, because before that it's not going to show anything and it is going to be deceiving, and again prescribing HRCT is going to cost the patient. So we have to take care of these kind of things when we are seeing the patients, and the doctor has to use moderation of everything, and excess of anything is bad. So, and the second question was that methylprednisolone and dexamethasone, which is better? Methylprednisolone, a hypothesis was made that methylprednisolone has a better penetrating power in the lung. So methylprednisolone fared out to be more better in the mortality ratio when it was compared to dexamethasone. Methylprednisolone had a better effect outcome after the when it was used for 28 days in the patients.
So,
Thank you.
yeah, Doctor,
Mute,
sir, you have
unmute.
Dr. Rakesh, you have to unmute yourself. You have to unmute yourself.
Why, I will like to add what Aditya has said, absolutely correct. Misuse of steroids, let it be at my end or let it be at Medanta's end, was tremendous. Every kind of combination, starting from 40 milligram IV 8 hourly to 125 milligram 8 hourly to the pulse therapy of 500 milligram IV OD, all has happened because patients are desperate, patients are not improving, clinician is desperate, because when he is facing, he is seeing his patient sliding down. But end of the day, when literature has been searched, mucor has come up, everybody, like last year when we were using tocilizumab like water, and suddenly we started seeing the complications of tocilizumab, things were pulled back because everybody was new into COVID, nobody knew what to do. Whatever things were coming, people were using it, initially getting good results, getting encouraged to use it again. But end of the day, we face the music, same music Europe does not face, America did not face, rest of the countries did not face of mucormycosis. Why we Indians have faced in the whole India? It is all injudicious use of steroids, not by Dr. Chawla, by everyone across. Nobody knew what exactly has to hold on. Wait with the smaller dosages of maximum dexamethasone of 6 milligram or methylprednisolone of 16 to 32 milligram or maximum 60 milligram, and hold on, wait for these drugs to work. Let you not be aggressive, and you must stop them, whether improvement or no improvement after 10 days. It should have been stopped absolutely, and this is what is being practiced across in Europe, in United States. If you go to their guidelines, their university guidelines, all should be stopped, and you wait for the things to work rather than keep on misusing it. So I am sure nobody knew exactly what was happening in the first wave, what was happening in the second wave. Second wave was disaster, nothing was working, nothing was working, so you are desperate. So you thought my increasing of steroids will help, giving pulse therapy will help, so nothing worked. And the take home message is, we have learnt a hard way as clinicians, but it should not be used more than recommended dose of 6 milligram OD or 16 milligram BD of methylprednisolone. One should restrict and not use it. Thank you.
So judicious use and restricted use of methylprednisolone steroids is very important. And the way the medicines were used injudiciously, they were the main cause of all this devastating effect of this treatment during this COVID second wave. So my third question is to Dr. Puneet Channa Sahab. Puneet Channa Sahab, we know that a lot of variants, new variants are now there, especially the Delta variant, as Dr. Rajiv has said. Delta variant is prevalent in India and in many other countries also it has gone. So the Delta variant, especially, it is quite contagious and quite deadly. And we know that this non-pharmaceutical measures, they have only controlled this second wave of the COVID-19 because of the restrictions, because of masking and other features, and the vaccination drive which is going on. Now, once this, we know that the virus has only been suppressed right now. It has not been eradicated. Now, there are a lot of asymptomatic COVID-19 carriers. So how we should go about with this silent COVID-19 carriers, and
Right.
how they will help in, because we know in the zero surveys also, whatever the figures are being displayed, the number of infections are much more. So what is the role of this COVID asymptomatic carrier in spreading the disease?
Very,
Very
very,
valid.
very, yeah,
Yeah.
sorry. Very valid question. And I would respond, and we have a lot of insights from the pulmonologists here, and also data from other panelists here. I would say the most plausible origin of SARS-CoV-2 is a natural selection of the virus in the animal host, followed by a zoonotic transfer, which means that, it started, somewhere in the animals and got transferred to the humans. While this happens, we can agree that, besides the respiratory nature which we have seen, which is the initial complication, We see that, it is wide-ranging complications are immunoinflammatory, thrombotic, and even parenchymal dearrangements. So when we talk about, the strains of the flu of the disease, I would say each strain of the flu or the coronavirus is a disease that confers to the future immunity on its sufferers. For such a disease, if almost everyone has had it, then those who have not had it are the people who should be protected from getting it, which is what is the concept of the herd immunity, and why the vaccines are being nowadays studied for various strains. We now have the Delta strain, Alpha strain, and a few more. There was a recent study that came up in an HIV patient that for her, that lady, in about a month's time, there are 30 different strains. But when we talk about the strains, we also talk about the mortality associated with the strains, or also the transmittability. The transmissibility is what we are looking at when it comes to the Delta strain, and we have reported that the mortality is slightly low in this case. However, the disease which is confirmed through an RT-PCR test, which we are using on day-to-day basis, is like Dr. Chawla also mentioned, would be also on the test basis, which is moderate, severe, based on the CT values what we get, or maybe the severity can be people have been using high density CT scans and so on for the 25 score, which helps us decide the therapy. However, coming on to the strains, I would say still countries have to do more of a whole genome sequencing, which will actually help us identify and confirm and validate what the new strains are before we go ahead and decide or on a guideline or a strategy how to treat them. Likewise, when we are looking at a herd immunity, which may be coming in, I think there will be questions which are still remaining to be answered in terms of that are we reaching a herd immunity, which is based on the vaccination, or we are reaching it on the basis of the infections that are there. Like hypothetically, I was writing an article lately. So if we imagine that there are three people who are infected by an infected person, so you keep multiplying hypothetically, for an example, that three will cause the disease to another three and another three and another three, right? So you have an exponential mathematics formula that can be created with this simple equation. Now, when we talk about if the number is one, so means one person is giving it to just one person more. So then the strain would have more transmissibility in case of when it is being transferred to three at a time, or the R value. I'm not going into that. So I'm just trying to keep it simple. In one case, we have one person transmitting to three others. In one case, we have one person transmitting to only one. The moment we talk about the three case, it is exponential, three times three, and so on. When we talk about one, then we are repeatedly multiplying. Then we see that the moment it comes to 0.999, the figure goes down. So it would say it is not an exponential growth, and it is an exponential decay, which is why we are trying to reach and vaccinate more people, or trying to reach the herd immunity, so-called, so that the transmittability is less than one person, which is 0.99, and the virus would die on its own. But then when we are talking about the published data and several other things associated, we have to agree amongst we as panelists that with a desire to help the patients quickly and to curb the pandemic, some decisions have been politicized or made hastily, if I have to say, on the basis of the anecdotal or the poorly verified evidence. Example is the use of ibuprofen, even steroids, as Dr. Chawla talked about, hydroxychloroquine, angiotensin converting enzymes, and maybe ARBs, which are the angiotensin receptor blockers, leponavir, ritonavir. I'll not go on to the remdesivir and other things we had in this. So besides the complications which we have because of this virus, I would say transmittability would also be covering to a certain extent the reinfections. I see more patients these days coming back with a tendency that I have got, even if it is a long COVID sometimes, or it is defined as a reinfection. But I feel a reinfection, which you asked me, a specific question is the transmittability. I think we need more robust assays or tests, if I have to call them, which can help us differentiate more clearly between a person who has recovered from COVID or a person and who is suspected as a reinfection, or a patient who is asymptomatic and or was a mild disease and was not noticed or tested or reported and is now out and spreading it to others. While we talk about the sero surveys, unfortunately, which are used to detect the SARS-CoV antibodies, are rapidly becoming available to us, but it is critical to estimate that the prevalence of the infections may not be rightly reported for the asymptomatic patients. So we have to see more robust assays. To date, I see, like I was telling you, the patients who are coming in are reinfection. I'm sure, and maybe Dr. Chavla and others can add that, we see that there is a steroid withdrawal syndrome, which is totally, or most of the times, if I have to say, is ignored in the patients. We see a very high fever in 24 to 36 hours, which can get elongated for another 1 week. And there are some guidelines which a lot of doctors would refer to and start again with the steroids and taper it back in. And many times they would swap between the methylprednisolone and get onto the dexamethasone or betamethasone, which are supposedly known by us physicians as 30 times more potent than the methylprednisolone. Workability and the data, I agree with Dr. Chavla, it may be much better. But I think, this reinfection is many a time missed out as steroid withdrawal syndrome, or I would say the androgen, emergencies, which we might have seen otherwise in emergency departments, or people who have been on steroids other than the COVID. So we should not forget the basic principles of our treatment before we get on to restart or reinfection being quoted for these patients. So in summary, I would say we would need more data to be shared, more sequencing that has to be come in. We have to talk about what are the other complications beyond the combination of the upper and the lower respiratory tract infections of the genre of the SARS-CoV virus, and look at the extrapulmonary clinical manifestations, and try and define more assays or treatment guidelines which can be more personalized to a patient and not personalized to a disease. I hope that answers that question.
Yeah,
I will like to
Sure.
add here,
yeah,
mask, mask, mask and distance is going to take you away from the asymptomatic spreaders. Don't allow anybody, it may look rude to you. The patients have a habit, mask को नीचे करना, as if I am talking to Dr. Sandeep Sharma. He is not able to listen it. वो mask को नीचे करके बात करेगा आपके साथ. Tell him very clearly, you want to talk, you talk, otherwise get out. You keep your mask above your nose and maintain a distance. That is the only way to be careful and away from the asymptomatic spreaders. There is no other option. And the same thing public has to learn. But I am afraid, as Sandeep and Dr. Puneet has told, the disease has not finished. It is suppressed. We have to see the gradual opening up of the city of Delhi, the places like Sadar Bazar, Chandni Chowk, ISBT, how things will be, the time will tell, how we behave, time will tell. And yes, no one of us is ready to see the same surge which we have witnessed.
Thank you, Dr. Chavla. Can
so
you throw light on if I may just, take your, Dr. Sharma, I can take your allowance on if
yeah.
you could throw some light on your experience on the withdrawal syndromes and the fever associated and things like
Sir,
that. So coming from a pulmonologist, it will be much better understood.
Sir, we should be very, very clear. As I've told you, when patient's fever is not settling with paracetamol, you are using Meftal, you are using the naproxen, which Ministry of Health has already advocated. You are using combination of naproxen and paracetamol. These are helping the patient's fever to settle down, not getting settled in mild and asymptomatic. You are adding steroids after 6 days and helping the fever to settle either in the hospital or in the house. Once the patient is discharged from the healthcare facility or in the house, when you have closed, you have tapered off the steroids and patient is all right, And after 4 days, 3 days, 5 days, again he started having fever. It is not a reinfection, sir. It is post COVID sequelae. You need not worry about it. You need not start the steroids again. You simply
Absolutely.
convince the patient, counsel the patient, and give him paracetamol and the required medicines for the symptoms. Things will get settled down sometimes in 4 days or 5 days, and there is nothing to get panicky, because this post COVID syndrome and post COVID sequelae or post COVID long haul syndrome is going to persist sometimes quite a long time, even up to 1 month, 45 days. So I agree with you. There is no need to again add on steroids as a steroid withdrawal syndrome.
Great. Thank you very much. Over to you, Dr. Sandeep.
Yeah, Dr. Rakesh sir, in addition to this, I would like to, because there is a panic in the post-COVID recovered patients now. So what we have seen, they are going as per their discretion with all the inflammatory markers every week, with D-dimer every week, investigations. Even I've seen many people, they are getting their RT-PCR done every third, fourth day. And what is your recommendation regarding this, sir? Investigations, especially all the inflammatory markers and the RT-PCR if required, when it should be done.
Sir, as Dr. Aditya has very clearly told, in moderate to severe patients, if they are admitted, you are advised by Ministry of Health to do CBC, LFT, KFT every day, but CRP and D dimer every 72 hours. HRCT, if required, there is no need to repeat. RT-PCR, the recommendation is there is no need to again do RT-PCR at all. But
Absolutely.
patients will persist. Sir, 10 दिन हो गए हैं, 15 दिन हो गए हैं, आप कराइए. You try to convince them, they don't listen. They have to get it done or they will come and fighting with you. आप इसलिए नहीं कराते हो कि रिकमेंडेशन है, आप इसलिए कराते हो कि इससे जान छुड़ा लें और इसका RT-PCR करा दें. When they go home, they will do CRP, they will do D dimer, they will do IL-6, they will do all kind of parameters, listening from across neighbors, friends, circle. If you ask me, as I told you, there is no need of any marker. If your oxygen is above 95, you don't have to worry about even the CT findings. If CT score is 7 by 25, 9 by 25, 11 by 25, no need to worry at all. These opacities will melt away. You need to have the oxygen checked up. That's what they should be bothered. Rather than bothering for that, they are more bothered for parameters, and they are coming, sir, ye बढ़ गया, ye kam ho gaya. Sir, ab kya kare? As he has said, is a post-COVID story. So it is very difficult. There is no recommendation. They should not be done at all, sir.
Right.
That's right, sir. So before going to Dr. Rajiv Jain, sir, may I request all the panelists, they can raise their hands or they can put their questions in the Q&A box so that I can take in between the other panelists. Dr. Gajendra, sir, yeah, you want to say something? So you have to unmute yourself.
Yes. See, one of the very important intervention as far as this COVID is concerned is wearing of a mask. But I am really astonished to see that more than 1.5 years has passed, and so far there are no standard for masks. People are just lapeting dupatta, hanky, or anything on their nose, just keeping over there and roaming about freely. Why there are no standards for masks? This is a very, very important thing which we must take care of. I would like the comments from
So not audible, sir.
not audible.
Yeah.
See, my point is,
You wanted a comment from whom, sir?
my point is why there are no standards, ISI standard or BI standards for the masks. People are just putting a hanky or single cloth or anything on their nose and are considering that they are safe, which they are not. Is it not the right time that the government should come out for the standardization of the masks?
So anyone would like to answer?
Sir, government has already guidelines to use a three-layered surgical mask, single-use disposable, which should be used ethically in the public place where you are roaming around or you are going across. We are using, when you are in the hospital premises, N95 mask, which is not very expensive now. It is 20, 22, 23 rupees. Good N95 mask you are get. The recent policy of double mask has come, keeping this new variant, which is an Indian variant, that you must use double mask. You put on your N95 mask and use surgical mask over N95 mask. If you say to be in the public place, as per this new variant, if possible, you can use this N95 mask by rotation policy. If you think it is expensive, you can use, have 5 masks, and you can use every fifth day the same mask and dispose these 5 masks at the end of 21 days. There is no need to again keep it in the sun or keep it in the car to re-sterilize. Just come home, keep it at the bottom, and use the another fresh, and after fifth day use the first one. You can use a 95 mask more economically in the public places, and you are more safe, more secure. If you are not able to do that, then you can have a single 1 rupee mask, surgical, three-layered, which should be of a good company. As we are hearing the news, the masks are washed and packed and repacked, and the gloves are packed and repacked. All guidelines have been set, sir. Public has to follow them. Everybody wants to make it a fashion statement कि मेरे सूट का मैचिंग, मेरे दुपट्टे का मैचिंग मास्क होना चाहिए, उस पर तिल्ला लगा होना चाहिए, उस पर बीड्स लगी होनी चाहिए. Bloody nonsense. It's all bullshit. The police has to be effective. They should catch them, go a nominal fine on them. People should get a message. Now everybody, even your big brands, have brought with the matching mask, matching shirt mask, matching suit mask. I think these things Dr. Gajendra Kumar has picked up rightly. This is not a fashion statement. This is a time to save yourself, and you can use a 95 mask costing 20 rupees, buying 100 rupees 5 masks and use them in 21 days and then dispose them off. That is the cheapest and the best option to save everybody. Like we used to say, your smoking is injurious to my health, so your not using mask is again injurious to my health. So this message has to go across.
Thank you. Thank you. Perfect.
Yes, the policies are there. The need is to implement them strictly and reinforce them. Now, my question to Dr. Rajiv Kumar Jain, sir, regarding vaccination drive in India. As you have rightly said, there is a lot of vaccine inequity, vaccine hesitancy, vaccine wastage, and non-availability of the vaccine. So, how government is going about it, and how we will cover the whole population or the maximum population to achieve herd immunity? As Dr. Puneet Chanda said, it is the right choice to get herd immunity through vaccine rather than through infection. So, how this vaccination coverage can be achieved in India, sir?
Very interesting discussion regarding the clinical aspects and the strategy to control. Regarding vaccination, it's so important that it has become a sheet anchor. But in the process, what is not been understood by the lay people is the vaccination and the mask and the social distancing have to go together. Vaccination will not protect against infection. People have to continue social distancing. That's part one. Part two is the production and distribution and administration of vaccination. The technology backup has been used as a policy in India because of simple reason that India is the top country in terms of holding a mobile phone and access to CSC, which is the largest base of service centers provided in the rural and semi-urban areas by Government of India. And this strategy has been proven to be very effective in reaching to the population at large in the shortest possible time, at the same time creating evidence of the dosages, because of the simple reason that these vaccine is not a single dose vaccine. If it would have been a single dose vaccine, things would have been different. For a 2-dose vaccine, the challenge is that people have to come back and know that they have to vaccinate again. So that challenge can only be bridged by a technology-based platform. The challenges to making this technology available on the ground are being modified, as you must have seen the last 2 months. A lot of innovations, and the latest innovation which has come out was yesterday. It is now available. Arogya Setu application is now available. CoWIN is available in 16 Indian languages. It is not only English now. Second, the investment that need to be made is not the only way to get the vaccine on the ground. Investment is in terms of making sure that the manufacturer is committed to supply at the place that is required to be supplied. The challenge in India is logistics as well. But you cannot forget the challenge is compounded by having a cold chain. Do we have cold chain equipment across India for that large scale? That is the last challenge that Indian government and the state government are trying to tackle. That cold chain equipment, which was available during poliomyelitis vaccination strategy, that is being used for outreach sessions. But you require much more certainty of the cold chain maintenance throughout the chain of manufacture, storage, and distribution. That is the biggest challenge now. Over that, the challenge of ensuring that since it's not a single dose vaccine, the vaccine comes in 10 doses, one vial has 10 doses. So you need 10 individuals, which becomes a challenge in rural population. In one area, there may not be 10 individuals who are available to administer before you open the vial. What happens? The wastage becomes a challenge over there. And if you've seen the analysis which I shown earlier, most of the states where the vaccine wastage has been high are those states which have substantial rural and tribal population and are hilly regions, which are difficult to reach. Take, for example, you must have seen pictures in the newspapers, how health workers are going, crossing rivers and reaching to individuals in, like, for example, even in Srinagar, Dal Lake, people are going by boat to administer the vaccine. So there, it may not be possible to have one vial with 10 individuals who have to receive the vaccine. So these factors determine the vaccine receipt status or vaccine success status in terms of giving the vaccine. But you cannot forget the second dimension, the vaccine hesitancy. There have been identified pockets where there has been definite substantive vaccine hesitancy as well as vaccine opposition. There are groups of individuals, there are groups of society, there are groups of cultures who do not still understand or do not take vaccine as a positive or a protective mechanism in their culture. So that was seen earlier in poliomyelitis as well. And we in India know this for sure. Though in Western world, it was a different kind of vaccine hesitancy where people in large population were opposing vaccination. In India, fortunately, that number is not that large. But in India, there is a culturally oriented vaccine hesitancy available. It has a religious connotation, it has cultural connotation, and that complicates the entire issue. At the same time, now you see the efforts of Government of India. A range of vaccine platforms, range of vaccine manufacturers, the two policies of helping Indian manufacturers get technology. The best initiative that Indian Foreign Service officers have done is engaging with the countries where vaccine has been manufactured and has not yet been supplied in terms of technology transfer. Now, US-India diplomatic mission has been reasonably successful, and Serum Institute as well as biologically are getting the technology for manufacture of vaccines in India. Last week, you must have seen the biggest success, advanced purchase agreements. The government of India for the first time paid 1,500 crores for purchasing 200 crore vaccines from 200 million doses of vaccine from biological E, which will be manufactured in India. The technology is not Indian. It has been transferred to India. So by July and August, you will see a definite change in terms of vaccine availability and ramp up of vaccine infrastructure. Last but not the least, the center-state dichotomy. In the beginning, it was clear that investment will have to be made for younger population by the state government. Only issue was who will procure. I believe now the state government and central government are reaching the consensus stage where government of India will ensure that the vaccine is made available and state government from their own funds pay the amount for the 18 to 44 population and devise their own strategy. Ultimately, you have to see it in a longer context. This is not the end of vaccination for COVID-19. This year will not be the end. Rather, this will be the beginning, because we are going to see booster doses. We are going to see another strategy of new vaccines being administered in the years to come. So it's going to stay. So whatever we do, we should see the long-term strategy of Government of India. And from that perspective, if you see the structure, by December 2021, we expect the population, majority population above 18 years of age, to have received the vaccination, at least one dose. That is what is committed. And with the strategy in place and with the kind of multi-pronged interventions at the international level, WHO level, COVAX facility, as well as Indian own production capacity, we believe, and I personally believe, we shall be successful, because over the last 4 months, more than 5 months, so to say, from 16 January to today, the 5th of June, we have been successful in administering to 19% of an Indian population. Imagine. We say we are a developing country, yet we have administered dosage which is the highest in amongst any country in the world in such a short time. And yet our economy is still functioning. Our structures are well in place. Our banking system is in place. Our transport is in place. So that, and our health infrastructure has got ramped up in such a short time, nobody could believe. So these two things together, I'm sure by 31st December 2021, and we shall meet again on 31st December 2021, we should actually be proud to see a substantive, more than 90% of population above 18 years having received at least one dose of vaccine, most of it manufactured in India. I think that is what is the great thing about Indian vaccination policy.
Thank you, sir. Let us hope you all get vaccinated. Those who have not received, at least they should receive the first dose of vaccination. So some panelists, they have raised their hands. Dr. Paman, let me go to Dr. Sanjeev Kulkarni first. Dr. Kulkarni is from Goa. Yeah. Dr. Kulkarni.
Yeah. Doc, I'm very thankful to Dr. Rajiv Jain for giving us such a very good update about what all is happening in India. But I still believe the simple things in life matter the most. And that is why I'm saying there's a lot of wastage of vaccines when there are not trained enough nurses. I mean, they know that there are at least 10 doses in each vial. So many times that has been, wasted, because after giving a Covishield vaccine, it can be preserved for some time in an ice cold, container. Maybe it is whatever your what do you call that?
Cold chain.
Vacation thing, vacation pouch or whatever. That is not happening, and that is why there is a lot of wastage, and that has to be reported and known to these governments that what you are doing is not really correct. You have to train the nurses or whoever is the vaccinator that there are so many doses per vial and they have to be used. Lot of, as I understand from Dr. Jain, that there's a lot of communication gap because of so many problems, logistics problems. Especially in Goa, we don't have that good connectivity. That I'm happy to know that today it is there. I can talk to you. Otherwise, there's a lot of this problem. So I'm very sure that when polio and other vaccinations were given, there was a lot of logistics problems that were solved. Now what is happening is only the government is doing it, only the collectors and other people are doing it. Why not at least now? Better late than never is what they say. Why not at least now involve those people who have been successful in giving those polio vaccines and other vaccines, so that these things will help a lot of motivation will be there, a lot of people will come and take the vaccinations. Now there is a new thing which has happened is in especially in Bombay, I think, that is about door to door vaccination, where what they want to do is they want to enforce or empanel societies to collaborate with private hospitals and get their people in the societies vaccinated. So there is one very good opportunity of why not involve our people who have already vaccinated so many children. They know the whole family. It's not only the children, they know the whole family. So this is my suggestion. You take it up and see what you want to do. Anything you can do.
Very, very nice ideas, no doubt. First of all, the wastage is an issue which even the Prime Minister in meeting yesterday has highlighted. It is the number one issue in terms of vaccination success in India. No dose should be wasted. The challenge is remote areas and hilly regions and tribal areas. The government is aware, and the strategy is being devised to reduce this vaccine wastage. Second, the difference between poliomyelitis and polio vaccination and this vaccine is it is an intramuscular vaccine that was, it was an oral vaccine. So the strategy is different. And all these vaccines, please remember, and you cannot forget that fact, all these vaccines have been authorized under emergency provisions. They are not regular vaccines as yet. None of the vaccine is a regular vaccine till date. It may be so after, say, 6 months or 1 year, but all these have been introduced in an emergency situation because of the pandemic. AEFI is a definite issue, and one should not lose sight of that. So there is a requirement of an oversight mechanism for at least 6 months to 1 year to go, when we know a lot more about different vaccines and the side effects due to the vaccine, or the success rate or the efficacy of the vaccines in real world. Last but not the least, one, if you recall the way vaccination has gone ahead in last 5 months, you would recall it has further spread on the ground. It is not confined to a hospital, number one. It is not confined to an institution, number two. It is not confined to urban areas. It is being given through the health and wellness centers. There are more than 32,000 health and wellness centers where community health officers are working. They are trained nurses. They are vaccinating in the rural hinterland in our country. If you look at the condition where this CHOs of HNWC, Health and Wellness Centers, are administering in rural, tribal, and hilly regions, you would really understand Goa is a better off state in terms of geography, but there are different states in India. If you go in the hinterland in northeastern part of the country, or even in Chhattisgarh, or even Jammu Kashmir, or Himachal, or Uttarakhand, you would realize the challenging environment under which these people are administering the vaccine. We are seeing a big change, and if those changes would not have come in the past, I mean the infrastructure on the ground, that is the health and wellness centers and community health officers having got 6-month training, and they are in place on the ground, mostly in rural areas, and they have all technology savvy. If we do not have ashas, who operate the mobile phones and they operate the tablets on the ground and they administer the vaccine, this would not have been possible to administer in the rural area. Currently, the focus of the government is to ramp up vaccination in semi-urban and rural areas. And that is the biggest challenge. When we talk of 19%, we forget mostly it is metros and urban state capitals. We do not understand the challenge, the real population, real infection, real challenge of vaccination, for that matter, any disease, is the semi-urban and rural areas. And that is a wide, very geographical, very a large area of our country where actual economy functions. And that is what we need to protect through vaccination. So that is what is happening now. And that I feel
I am talking, I am
the challenge, and that government is taking care.
Yeah.
And now we will go for a very short, crisp questions and crisp answers. That will be a rapid round type. Dr. Pawan, yes.
Yes, sir. Thank you so much, Dr. Sharma, for giving the opportunity. Actually, I was waiting to see Dr. Rakesh Chawla once again on screen. And thank you so much, Dr. Chawla, for spending your time. I have 2-3 questions, very quick one, as Dr. Sharma has mentioned. One, patient is managing himself in a COVID situation at 1 to 2 liters at home. Oxygen saturation is 94, 95%. All of us family gets into panic mode. They take the patient to the hospital. And all of a sudden, I mean, they have been managing for 24 hours or maybe for 48 hours also. When they reach hospital, immediately after 3-4 hours, they learn that patient has been put on 10 liters, 12 liters, 15 liters immediately. At home, last 20 to 48 hours, they were managing at 1 to 3 liters with concentrator or cylinder, and the patient was fine. This is one. Secondly, so what could it be the most shocking incidences have been the CPAs. And when the patients have not been attended, because it's a COVID patient, nobody will be able to give the CPR. I mean, nobody is going to give mouth to mouth. They have the mechanism, but by the time person is reaching, because patients are either there are too many and there are shortage of staff, CPAs were probably not managed. Your views and opinion on that. These are the 2 questions. Since we have to be short, there is one more very crisp, very critical question, Dr. Chawla, but I'll ask it if I'll be permitted. Your views on these 2 questions. These have been bothering me since very long, actually.
Well, you are absolutely correct. What is happening? Why I discouraged use of, see, you did not have enough oxygen concentrators which give oxygen at 5 liters per minute, up to 5 liters per minute.
Yeah.
Even few which are good companies, they are able to say that 7 liters they have the oxygen concentrators. Oxygen cylinder keeping on the bedside of the patient, using it for 10 minutes, 20 minutes, oxygen 94, 95, and switching it off. What public is doing, public doesn't know they have to use it for 24 hours continuously for 5 to 7 days. They don't have enough backup. Market oxygen is not available. That is a false sense of well-being. Keeping a cylinder that he needs oxygen, we are able to make it 94, 95, and then switching it off. You don't have enough supply to back up the cylinder, because the small D-type cylinder finishes if you are using at 4 liters per minute in another 4 to 5 hours. It will finish. You have a cylinder, it will finish overnight or by next 24 hours. And you don't have enough supply to back up. And you actually do not know what to do. This is the problem. If beginning of less than 93, you are in a healthcare facility where there is a non-stop oxygen supply, at least you are safe as far as oxygen is concerned. That was the biggest reason I discourage people using cylinders at home. They don't realize keeping cylinder is not giving you a security. Keeping cylinder is more dangerous because you don't have a backup to fill up, and
Correct.
government does not have adequate supply to give the backup. So
Correct,
that
sir.
then oxygen concentrators were not enough. You have heard all kind of news hoarding of oxygen
Correct.
concentrator, and everything was going on.
Correct, sir.
Second question, that patient reaches the healthcare facility. Now the oxygen requirement is 93, 94. You do not know what they were doing at home, how much oxygen they were using at, and how much they were discounting their oxygen so that ye raat ko bhi chal jaye cylinder, aage bhi chal jaye cylinder. So that's a very big issue when somebody is using oxygen at home.
सर मैं
And
कॉन्सेंट्रेटर्स की बात कर रहा हूँ कि उनको कंटिन्यूअस 1-2 लीटर पे थे, हॉस्पिटल पहुंचे 48 घंटे के बाद तो 15 लीटर पे डाला इमीडिएटली या 12 लीटर पे डाला और 24 से 48 घंटे मैनेज करा था उन्होंने.
सर ये
कई
ना
केसेस.
सर बड़ी डाइसी सी सिचुएशन है.
Correct,
You
sir.
are correct. You are correct on one side. You cannot be there. I cannot be there all the time. आया उसने ऑक्सीजन का बॉल भी खोल दिया ताकि पेशेंट की सेचुरेशन 95 100 हो जाए, और उसके बाद ये भूल गया कि उसको नीचे भी करना है, उसको टाइट्रेट भी करना है, उसको कम करना है. दिस इज वन विच इज अ practical issue which sisters, as they say, the vaccinator to be trained, the sisters and nurses to use the oxygen judiciously at healthcare center. Otherwise, if the patient is maintained at 2 liters at home with oxygen concentrator and is buying time to reach that healthcare facility, there is no reason that he should not be maintained at the same amount of oxygen what he was using at home,
Correct, sir.
except to have a continuous supply, right?
Correct,
So
sir.
there
Correct.
is no reason about it. What you said is correct. It happens, but they are overworked. They forget to titrate it back. They come patient saturating पूरा खोल दिया, उसके बाद वापस भी आना है, वो भूल गए. You are
Okay.
absolutely right. So it was your related to your oxygen, your cylinder. What was the second question?
CPA कार्डियोपल्मोनरी अरेस्ट सर. वैसे CPR दे नहीं सकते.
Let me tell you, no. If you get to the tertiary care centers where dedicated COVID RICUs are there, like my hospital, or big hospitals like BLK, Medanta, Max, the residents are doing CPR, sir. Let it be an honest. The problem happening is if there are too many CPRs at the same time, yes, patient gets neglected. If it is one or two in that night, it happens. But there is a fear, definite fear amongst the resident doctors. I need not, because I think all doctors are sitting here, so I can say everybody is afraid, sir. Let me tell you my experience. The residents try to be minimum in that full COVID
Yes.
atmosphere. All aerosol generating procedures are going on, starting from the oxygen inhalation to the steam, the nebulization to the endotracheal intubation. There are too much of aerosol generated in that
Correct.
atmosphere. So they try when unnecessarily better to be in a doctor's duty room rather than sitting there. But at the when it is required, they are doing CPR. Yes, hesitancy is there. There is no denial about it. But things are being done, things are being managed. But practically, the problem is this variant. If the patient has gone on ventilator in the highest of the centers, in the best of the centers of the country, I have a data from Vellore, I have data from Apollo Chennai, I have data from Apollo and Yashoda Hyderabad, from Max Saket, Gurgaon Fortis, Medanta, BLK. None of the patient going on ventilator has survived.
Oh.
It's a very bitter truth, but it has happened. It has happened. So with the period and with the experience, when you are putting the patient on ventilator, you know it heart of heart, the game is lost. Two things I will add, interesting to add to the vaccination, to the clinician perspective. As last time Professor Gajendra Kumar said, what about the duration and what about the booster? Right? Because now first vaccination was done in January. Now it is already 4 5 months. Another 3 months, booster problem is going to start. Still, country has to get vaccinated. Number two, the duration. Today itself, the trial was there already a month back when they have said that first vaccine first vaccine, even if you are doing to the public without having a backup of the second vaccine, it's going to be useless, especially for this strain, which is your Delta strain. It is 30.2% effective, even with the Pfizer or with the Covishield. Once you vaccinate the second one, it goes to 60% or 70% with Covishield and 80% with the Pfizer biotech vaccine. So you have to vaccinate at the earliest. The time is reducing again to 5 to 6 weeks. Professor Gajendra Kumar, the government of India is going to do it so that the public should get safety and they should be vaccinated at the earliest with the second dose, rather giving one dose and keeping the population unprotected without having giving a second dose in time. This whole decision of 12 weeks, we know why these things are happening and we know our compulsions. So these are two very important things of the vaccination from clinician perspective I wanted to address before you close. Right.
So vaccination, what about the antibodies which have gone into thousands, 40,000, 20,000, hundreds,
So
500? That is okay?
another important issue of antibodies. Government of India or world over, once you are vaccinated with 2 dosages, there is no recommendation to check the antibodies. Your recommendation is, as you have said about RT-PCR, there is no recommendation to check the antibodies because your cell mediated immunity, there are four kind of antibodies. You need to have neutralizing killing antibodies to measure. Then there are RBD antibodies, which no lab has got except the advanced lab to measure. It is your self-mediated immunity which is trained to look after you after second vaccine. So even if you don't have an antibody and I come to the vaccinated center for the third booster and still there are no antibodies, what you will say? You will say the vaccine is not effective. Vaccine is effective. The maximum population has to be vaccinated with the 2 dosages at the earliest. That is a problem. Our politicians are a nonsense in our system. You start when vaccine was available, not to be sent because should not waste. You did a good friendly gesture to the neighboring countries. कभी वो कहते हैं सुअर की चर्बी है इसमें, कभी कहते हैं मोदी ने नहीं लगवाया, कभी कहते हैं ये, कभी कहते हैं वो. Now when they have understood, मोदी ने भी लगवा लिया, or vaccine is the only answer to the end of the pandemic. Now they say 24 घंटे में you must vaccinate the whole country. You understand? So these dogla politicians are killing the country rather than helping the country. They should be kept in line and bloody fired. I am telling you honestly, they are the spoil game of the country which is progressing. As he has said, 22 crore people have been vaccinated. It's not a joke. It is not possible. A developing country has done this job. But we are here कि डॉक्टर सुधीर शर्मा ग्रो क्यों कर रहे हैं? इनकी कमीज मेरी कमीज से सफेद क्यों है? Why BJP is doing this job? They're politicizing everything, which is the utter nonsense in our country. I'm sorry to say.
Right, sir. So we should go by the scientific evidences, and we should follow the scientific evidences and the authentic information regarding vaccination or any other treatment regarding news. So,
Dr. Sharma, can I add
from
to a point to Dr. Pawan?
Dr. Guru Prasad. Once a minute, sir. Dr. Guru Prasad from ExxonMobil, Bangalore. Dr. Guru Prasad.
Yes, thank you, Dr. Sandeep. Yes, thank you, Dr. Sandeep. So now we know that there is high probability of airborne transmission, and also the principal scientific advisor to Government of India also highlighted this in his recommendation to Government of India, which stressed the importance of good ventilation, especially the use of exhaust fans in homes, offices, and also corporate, the buildings. Now, should the corporates first invest on that and change their ventilation before allowing the employees in?
In fact, that is what should be the top priority. If we have to get our workplaces going, working for a longer term, a war footing ventilation strategy is to be adopted all across the workplaces, including factories and including offices and hospitals as well. If you look at many of the hospitals, the weakest link is the air conditioning, the filters in the air conditioning. and that could be a source of transmission in healthcare settings in our country. What has happened? We, in the process of development of healthcare infrastructure and offices and factories, we've gone for a very centralized system of air conditioning without having support system to maintain a very high level of filtration and air changes that are required to control airborne transmission of, or not only COVID, but also other viral and bacterial infections at the workplaces. This is what should be the biggest scientific learning in the past 2-3 months. There is no doubt that the scientific committee, including the WHO, have accepted the reality of transmission of COVID-19 being airborne in addition to being droplet. So the mask is not the only solution. Mask and ventilation in closed spaces is the solution, which is the only sustainable solution in the months and years to come. And ventilation should be a very important intervention, and reform, reorientation, auditing of the ventilation is of utmost importance. It should be done today, not tomorrow, because tomorrow we have to prepare for the unlockdown. Unlockdown cannot happen unless effective on-ground ventilation strategy has been implemented. This is as important as giving infrastructure in terms of oxygen availability or concentrators and trained manpower. You cannot separate the two.
It means offices, they should maintain the ventilation norms before allowing the workers to come to the to join the at the workplace.
Very true.
Anything to
Very
Dr. Chawla? Anything to add, Dr. Rakesh Chawla?
Sir, you are absolutely correct. Droplet infection, airborne up to 10 meters. They are the mask, again, a very good prevention. But as you said, the ventilation, cross ventilation, if you see these newer coming up hospitals, they are like the boxes. They are centrally air conditioned, but they are like the boxes. You enter, there is no exit of your OPD rooms, there is no exit of the air from your corridors. They are on one sided entry, and behind is a small door. If you just go through in your mind of the new developing nursing homes or your hospitals, that concept of having a big corridors and open hospital like government hospitals, the big hospitals used to be. Now, even if you see any hospital infrastructure, it is closed and with a beautiful front and beautiful back. And if you go inside the rooms, ventilation is there, exhaust is there, but you don't have an inlet except an AC inlet inside. Absolutely true. As you have shown the taxi or the auto rickshaw, that ventilation is the concept to avoid the infection.
Dr. Rakesh Chawla, sir, again coming back to the steroids, there is one question from our panelist, Shivangi Garg. She is actually the daughter of one of our esteemed panelists, and he had suffered from COVID. Now he has recovered, he is recovering, and she is in Germany, and she wants to ask one question. Is there any way after recovery to cope up from any damage of the steroids may have done to the patient? How long should we continue steroids, sir?
See, Shivangi, whatever I told you, hypocrisy is big in our profession. What exactly was done and what is to be done, these are two different things. Whatever amount of steroids have been used in your case, just forget about. You have recovered, steroids have been tapered off with the time. If you have no issues, don't think about any bad effect of steroids. I tell about to my patients is steroids are like atom bomb, right? You use them on Hiroshima, Nagasaki, they are destroyers. Use them in Tarapur plant, they are electricity, right? So whatever way you have survived, you have come, you are a COVID winner. Forget about whatever steroids were used. There is no residual effect on your body system. If they have been tapered off normally, just be cool and be comfortable. Take good diet, take nourishment, and forget about Whatever has happened should have happened. If nothing is there, forget about, nothing will happen. You will remain safe and sound if steroids have been stopped.
Thank you very much,
Doctor,
Dr. Chawla.
yeah,
Doctor,
Dr. Rakesh Chawla, sir, another question. What is your experience regarding this tocilizumab and IVIG, these new medicines like 2DG or the Regeneron therapy? Have you, uh, what is your experience in the recovery of the patient? Both
Sir,
Dr. Chawlas, they can, yeah.
sir, I told you last wave tocilizumab was new to all of us, and we saved patients with tocilizumab, miraculous escape of the patients with tocilizumab. But when we saw the abdominal gut perforation secondary to tocilizumab, mucormycosis of the gut secondary to tocilizumab, massive bleeding from the gut and perrectal bleeding from tocilizumab, we were so much afraid. It was the end of the wave when we faced the side effects because of the medicines which we used as a severe medicine. But this wave, when it came, government of India realized from the first wave the way the tocilizumab was used, the way the people were running after the drug, the way black marketing was happening. This year government was very cautious. They know it destroys your immune system. They know it is again the cause for mucormycosis. It is not only steroids, it is not only diabetes, because steroids are being, there are full specialty of rheumatology on steroids. There are full connective tissue disorders of the lung on steroids. All asthmatics are on steroids. But you have never seen mucormycosis in any of these patients. You are using oxygen humidifiers. You are using the water in the normal tap water in your oxygen tank, oxygen containers where the oxygen is being humidified. You have never seen mucormycosis. It is not the cause of mucormycosis. Uncontrolled diabetes, immunocompromised status, injudicious steroids with diabetes, use of tocilizumab, they were the causes, they are the causes of mucormycosis. So government has taken control of tocilizumab, that you have even hospital as a committee. You want tocilizumab, write the indication for tocilizumab, send it to the central committee. Government of Delhi has made it in LNJP. Within a day, 3 times they meet and they clear whether they are required or no. In Haryana, same way, any hospital needing tocilizumab goes to PGIMS Rohtak. They clear tocilizumab or they don't clear tocilizumab depending upon the indication. So tocilizumab is a good drug, but it has to be used very judiciously and in a very severely critical ill patient. Yes, if you use it timely, it helps. Then you don't have to worry about the side effects, because you are measuring the life as the side effects. When you know you are able to save the life, forget about the side effects. But injudicious use की डॉक्टर चावला ने टॉसलिजुमैब किया तो मैं भी लगा सकता हूँ, मैं भी दे सकता हूँ. This kind of an indication has finished and it should be used, but very, very judiciously. Coming to the new drug, which is 2DG or pegylated interferon or IVIG, we have used all these drugs, and another drug, bevacizumab, South India has used in plenty. There was only trial in China and in Italy for 28 patients. I told you it is a desperate situation. Whatever new drug comes with little positive results, you start seeing it as a ray of life, silver line in life, that you can save the patient. So somebody has used in 7 patients, somebody has used in 10 patients, and you cannot say ki I used it so I saved. They are the patients which are mild to moderate. They would have been all right anyway. You use IVIG, you use bevacizumab, you use 2DG. So these patients would have been all right by their own. There are big hype now about 2DG, telling that yes, it you give a wrong glucose to the virus, it stops replicating. Correct. But what about the symptoms? Do the symptoms improve after giving 2DG? That is another very important thing to be discussed. I told you there is only single parameter of evaluating your patient of COVID is an oxygen. If oxygen requirement is going high, patient is sick, and sick, all parameters are disturbed. If your oxygen requirement is coming down, your patient is recovering. Your all parameters are getting corrected. आपको कुछ भी करना नहीं है. You use your medicines. You have the steroids in controlled dose, low molecular weight heparin in controlled dose, and the oxygen. Use antibiotics if there is a secondary infection. These are the drugs available to you for mild to moderate cases. Once the patient is a cytokine storm, moderate to severe, nothing works. Believe it, sir. Whatever has to be done, it is at the milder to moderate step. And when you need these medicines, they are not available to the public. They are yet to be made. Now the wave has almost gone, as you have seen the epidemiological data. Now they are marketing it in 900 rupees a pack and 1000 rupees a pack. I pray to God this should not come again. We, our country, our people should not suffer again. These all drugs are useful in mild to moderate category patients, not from moderate to severe category, sir.
Another question to you, sir. For the treatment of COVID, what our experience shows, oxygen is necessary. Symptomatic treatment is necessary in mild and moderate cases. Then, uh, once they are admitted, it should be at the discretion at the end as per the requirement of the patient, which drug should be administered, whether it is remdesivir or whether tocilizumab or whether any other drug which are being introduced in the new treatment modalities. Now, another question which arises: people are being given this blood thinners. So these blood thinners, can they be started when they are in during home isolation period, or which is the best blood thinner which should be started during this?
Sir, sir, yes, Dr. Aditya wants to speak.
Dr. Aditya wants to speak.
Yeah, I wanted to say that the best blood thinner is enoxaparin right now. That is only zero point 0.5 units of subcutaneous once a day. That has been given by the guidelines of Ministry of Health. That can be started only as a prophylactic thing. But therapeutic also, it is given that only once a day it should be given. If there is any existing renal disease, fundapinux or unfractionated heparin should be thought of. Otherwise, only Clexane, only enoxaparin should be given.
So enoxaparin, Eliquis 2.5 or 5 milligram, that can be
The
given.
people are using Apixaban, people are using all those, but only the study drug was rivaroxaban and enoxaparin.
Okay. So subcutaneous is much better, and it should be started when advised by a physician. Then another
Yeah.
question, sir, there are also a lot of queries about the anti-fibrinolytic drugs. Some people they are advising Nintana, some are advising this Perphenex. So
Sir,
which needs
antifibrotics are thought to have a role in post-COVID fibrosis, but still the outcome has yet to be observed. Nintedanib and Perfinex has been used in the patients, but nintedanib has its own side effects. Like if it is used with the Clexane, like blood thinners, it causes immense bleeding, and these should be used only in post-COVID fibrosis after when 2 to 3 months have passed in the fibrosis, the CT is not clearing up. Otherwise, these opacities, as said by Dr. Chawla, these melt away on their own. You don't need any antifibrotics for that. Still, the role is thought to be of benefit, and they can be given if the patient is not improving after 2 to 3 months.
but what we are seeing right now, the patients are being discharged on these drugs, and
That
maybe
is,
to prevent.
Dr. Sandeep,
Yeah,
Dr. Sandeep, that is absolutely wrong. There is no indication of antifibrotics in the active management of COVID-19 disease, because the opacities which you are seeing are not the fibrotic opacities, they are the thrombotic opacities. This COVID pneumonia is not community acquired pneumonia or ventilated associated pneumonia. This pneumonia is different from what we are seeing in respiratory medicine, acquired pneumonias, ventilated associated pneumonias. So these are the thrombotic opacities which are non-infective. They are going to melt away provided you give the time to these opacities to go. That's why I said, if Your 6 minute walk test is correct. You are able to do 6 minute walk test and you are not desaturating. There is no need to do again an HRCT. The question is HRCT कब किया जाए? कभी भी नहीं किया जाए अगर आपका 6 minute walk test is clear and you are not desaturating. These opacities will disappear with period of time. You have to have a patience. There is no role proved of antifibrotics, but since these are antifibrotic drugs, so people think in the fibrotic pathway of the body through which the fibrogenesis happens, these drugs may help. So things are in progress. Let us see what reports come finally, whether there is an RCT or it comes. So it is everybody's individual experience of using the antifibrotics, but believe they have no role.
So antifibrotic, they should be started only after the patient has recovered from COVID and all this COVID pneumonia has.
So if again, it is again disputed if you are using it as an antifibrotic with your experience. You say they are against fibrogenesis, so I am using it. They may interfere in any of the pathway through which the fibrogenesis happens, or patient has got a previous history of ILD, which is already there, or patients are like pre-diabetic. Their body system or immune system is pre-fibrogenic, and with COVID-19, that fibrogenesis get accelerated, like diabetes in COVID-19 is getting accelerated in the patients. So you may be correct of using it, but as such, there is no recommendations.
Dr. Rakesh Chawla sir, another question, like during this second wave, we know a lot of people have been affected, a lot of families, they have been devastated. And people, although the numbers are now reducing, people say the wave is now down, that it has plateaued, it is now going down. Now we should open up and other things, whatever signs of improvements are there. But what we are seeing, sir, lot of people who had been affected and they were hospitalized, they are in COVID ICUs, and they are either on BiPAP or on ventilators. Now they are requiring ECMO, or they are being advised lung transplantation, and we need to address these issues also. So can you throw some light on these issues, because in many cases we have to take decision, we have to advise our management also, what is our role to play in this.
Sir, you are absolutely correct. If 100% people have suffered from COVID, 12% people are absolutely escort free. Those who are asymptomatic are asymptomatic. Those who have come from ICUs, 80% people are suffering from post COVID syndrome, which may be fatigue, which may be feeling feverish, which may be malaise, sleep disturbances, gastro disturbances, unwellness, chronic cough, and paresthesias, headache, forgetfulness, and dropping dead during the excessive exercise. What you have seen one of the celebrities of Indigo Airlines doing the cycling and he dropped dead. It's a known complication of the post COVID. One has to be very, very in tachycardias, myocarditis, cardiac complications. These are all post COVID syndrome. Long post COVID fibrosis is another an issue. Now, as you said, the patients being discharged on non-invasive ventilation, they are not able to get their oxygen maintained because they have to be discharged on BiPAP or NIV. True, these are the patients who are recovering, and after that there is no recovery. Their way of living becomes a post the NIV. Now, question comes, if the patient is on ventilatory failure, then you need a lung bypass machine like the renal bypass, like the heart transplant. When you are doing the CABG, you bypass the heart. So, similarly, you bypass the lung through the ECMO machine, in which the blood is being circulated and oxygenated through the machine and supplied. So, 60% of the machine takes over, 40% still the lungs keep on taking it. So the ECMO should be done when the patient is on a minimum mode of ventilation and patient is oriented and patient is conscious on ventilator. You are taking ECMO sometimes by giving rest to the lungs. Patients are bailed out with ECMO, or ECMO is a platform where you station your patient till you arrange for the lung transplant. So the patients who are advanced age with severe illness, prolonged ICU stay, on mechanical ventilation, history of smoking, chronic alcoholism are the candidates who are more prone to get their lungs post COVID fibrosis on ECMO and going in for the lung transplant. So, transplant lung again is not an easy job because in COVID, people have an experience that unilateral lung transplant does not work. So, it is better to give the bilateral lung transplant, and they have seen the lung becomes solid like a stone. So last presentations which I wanted to do, I could have shown you how those that the lung looks like. So these are the predisposing. The IL-6 is very high post discharge, CRP is very high post discharge, patient has a tendency to develop fibrosis. So these are the patients who will get the the extensive fibrosis in the lung. Again question comes, steroids should be continued if the patient is on BiPAP and you are discharging the patient with the fibrotic lung. So as I said, nintedanib has no role, and it can increase, as Dr. Aditya said, the possibility of bleeding when you are giving it with the blood thinners. So treatment is the oxygen support, pulmonary rehabilitation, another subject which has to be discussed in details, anticoagulation, vaccination, and you come down to the lung transplant. So when you come down to the word of lung transplant, so various indications where you should be able to do, because lung is totally fibrosed, it has got the vessels are totally thrombosed, and there is an acute inflammation, there is an acute fibrosis in the lung. So these are the patients which will need lung transplant. So if the patient you see for the transplant, that patient will be able to survive 90 days after the lung transplant, or patient has a survival, you see the 2 years, if the patient gets lung transplant he will survive. So these are the patients should be offered. So otherwise, if you see, the indications are age less than 65 years, if there is a single organ dysfunction, or there is a sufficient time should be allowed for the lung to recover, patient is able to participate post lung transplant in the pulmonary rehabilitation program, because that's very very important. Doing surgery and coming out is not only thing. After doing surgery, taking care of the transplant lung, because the fungal diseases are extensive, the opportunistic pathogens are extensive, patient is on immunocompromised drugs. So this is very very important that he is able to participate in rehabilitation program. Patient should fulfill the criteria of transplant, and the center has got enough experience of having the ECMO bridge and having a lung transplant. So they should be able to arrange the donor also before asking or lifting the patient for the transplant. We know COVID-19 is a new indication for the lung transplant. Apart from this, the patients of end stage ILD, end stage COPD, end stage pulmonary hypertension, and patients of cystic fibrosis used to be the indications for the lung transplant. But now COVID-19 is a new indication where the patients have been offered, and the centers in South, in Hyderabad, Yashoda or KIMS or MGM Chennai, they have been able to do the lung transplant in these COVID patients. They have an experience around say 24, 25 patients of bilateral lung transplant. But again, lung transplant, there is an issue of the donor, the recipient factors, acceptability by the government, making it a government aided program. This whole thing is going on in the private way. So the government participation is very, very important for the making the registry more strong, from where you can have these cadaveric lungs so that you are able to facilitate the lung transplant.
Thank you, Dr. Rakesh Chawla sir. A lot of queries have been resolved, and a lot of questions which were there in our minds and in the minds of the learned participant, they have been answered. Dr. Sanjeev Kulkarni's, your hand is raised. Still, I think you have already taken your question. And before you have any other questions, sir? Dr.
Yeah,
Kulkarni?
uh, Dr. Sandeep, I want to ask Dr. R. Chawla about the immunization thing. You know, after 2 doses of Covishield vaccine, 6 to 7 weeks apart, I think I have read it in the Lancet or the ICMR guidelines, where it says there is now, after the new studies, it says 10 months of immunity is what you will get. Is that right, Dr. Chawla?
Well, the question came for the patients who suffered from COVID. Post COVID is as good as you are vaccinated. They are the
Okay.
natural antibodies. And here you are creating the antibodies by generating the body immune response. So in Science, this was published that these post COVID or these antibodies should remain. Post COVID patients' antibodies remain at least for 8 months. That is without doubt that you don't have to worry about. That's why the vaccination of these post COVID patient is kept at least 90 days, that you need not get vaccinated for 90 days. Regarding these antibodies, till how many days it will persist, because the all researches started somewhere around April or May 2020, when they started getting these subjects and they started vaccinating them, and the data is still not disclosed that in them antibody level is reducing and how much time it is going to be there, because that is going to decide your booster. People are looking for booster is that second dose, and post second dose time is going to decide when these antibodies will fade away, and the data will come when you are going to have the booster. So that is going to answer your question. Is absolutely valid. I am sure the moment the data is out, it is the antibodies are reducing less than required level. Is it 10 months or 9 months or 11 months? Government is going, the world is going to come up with the booster dosages.
Sir, just to add, thank you very much. Just to add, there is a Nature study 4 days ago which talks about antibodies may be there for lifetime. So allow me to just give you a excerpt from the study, which is from Nature, which is the antibody proteins that can recognize and help to inactivate the viral particles are the key to the immune defense. After a new infection, the short-lived cells are in the plasma blasts. But post the couple of days of infection, because we are checking that in the blood. But now there are cells which are called as the bone marrow plasma cells, which actually go and hide into the bones and trickling the antibodies for decades as and when it is needed, which is what happens in the vaccination. I am sure to a certain extent, Dr. Rajiv Jain, who is a pediatrician, would agree. Post a vaccination, the antibodies may stay if you look at the bone marrow plasma cells. So this is a Nature study, one can look at it. And it is believed that, more research is going in. Like Dr. Chawla also said, more data is coming in. But it is also believed that in some cases, if we look at the bone marrow cells, plasma cells in the bone marrow, which are hidden, we may be able to actually decipher the study much more further and confirm that the antibodies may be there for a lifetime, or at least for a couple of decades.
Sir,
At least, Dr. Chandna, what you
Yeah.
said, Nature Medicine article is very categorical on this aspect. And that is very scientific, I believe, because plasma cells
Thank
in the
you.
bone marrow are the key to long-term immunity. But it does not factor in the mutation that will happen or the variant that will evolve. For that particular gene
And
or
evolving,
particular
yeah.
Evolving situation, we do not know. Yes, for maybe Delta variant, fine. It is there. It is almost lifelong, but the organism changes. So there are confounding factors. Current evidence, 1 year is available.
Yeah.
That article that you're quoting in Nature Medicine is very, very. I think it gives very substantive evidence to that.
Right.
Thank you for
Thank you.
highlighting that aspect.
Thank you. Thank you.
Dr. Rakesh,
COVID-19, still, I will say, as a clinician core dealing with COVID-19, we have patients who had COVID positive. They got vaccinated. Second vaccination, 12 weeks, again COVID positive. Again COVID positive. Where is this lifetime immunity, sir? So
Right.
there are contradiction. We have cases and number on records. All of you have this experience that patients are vaccinated fully and they are again COVID positive.
Of
And
course, we need
not
more
only
data on
they
this.
are
Yeah.
positive, the family is positive, the whole family is being vaccinated. So there are a lot of contradictions about this. As Sarah said regarding the variants, by the time we reach up to the variant and the virus changes its colors and gives you another 1 year to run after this. So it's a very difficult say if you see the practical ground reality and what the literature is supporting, sir.
Maybe we need to understand more on the pathogenicity of the virus still.
Dr. Sandeep,
And better testing.
Dr. Tyagarajan, take as the last question.
Yeah,
Sure.
so Dr. Rakesh Chawla sir, Dr. Aditya, and Dr. Puneet Chanda and Dr. Ajay Kumar Jain, lot of insight on this enigma about COVID-19. It was discussed and deliberated today. Sir, there is no end to this discussion. We have already spent about 2.5 hours on this, and very lively, very well-oriented, fruitful discussion was there. But still, sir, we would like to call you on some panel discussion. Maybe few topics are left, and like post-COVID syndrome and the complications like mucormycosis and the multiple organ this inflammatory syndrome in children. They are the interesting topics which we can discuss later on. And before concluding, sir, may I request Dr. Munishwar Tyagarajan sir to give his last comment or any question from the esteemed panelists, sir. Dr. Tyagarajan from Bangalore.
Yes, sir. Good evening, sir. Our Honorable General Secretary, very lively, what he has asked a question about what the common man is facing and what the doctor is facing. What is this? The early itself, he asked the question, and you have very nicely answered, sir, like a magician, and you have answered almost all questions. Sir, one thing I wanted to tell you, this especially, this COVID, and because of these variants, this 95 to 100 SpO2 or the saturation is okay if it is a home quarantine, because now a lot of people have not been vaccinated and a lot of people are only one dose has been given and variant is there, alpha to delta. I think below 90, that is 70 to 90 or 80 to 90, I think we need a tertiary hospital where there should be an intensivist, where there should be pulmonologist. Otherwise, we will face a lot of problem, because we have seen lot of kith and kin, what lot of educated people, lot of people have been died because we are not getting the proper treatment what we are expected to do. Because I am following lot of cases, people with a small hospitals, they will put ICU and they collect extraordinary money, and now the patients are also hitting these doctors, and unfortunately they are also suffering and patients also dying. I think we need an intensivist, we need a tertiary hospital, we need a pulmonologist, because they are the educated, they know what to do. At least they can do the better, and the outcome will be the better. And in future, we need a very good tertiary care. Otherwise, it will be disaster in future, because we will have a lot of comorbidity, lot of post-COVID complications, and lot of youngsters we have not taken vaccine. I have seen many of kith and kin have been, they have vanished, they have died. And because of that pain, I am telling, in Karnataka, out of 100 and 200 hospital patients die means in the hospital, really 180 are dying in the hospital. Sir, thank you. If you have any comments, please say, sir.
Thank you. I agree with you 100%, sir. You are absolutely correct. And your reading is absolutely correct. This is the problem because we have no accountability in our country. There are no set guidelines in our country. If in USA or UK you start writing Alprex little more than required and the prescriptions are screened by the government, they send you a love letter, Dr. Chawla, epidemic of insomnia has walked in. You are writing so much of Alprex. You are writing there so many medicines over the counter, sir. Our system is to blame for this. As Dr. Sandeep has said, we are not going to go on that line, but accountability has to be there in every profession. I will not say only in my profession. Yes, that is the reason. And I agree with you, Dr. Tyagraju. What you said is absolutely correct.
Chawla sir, Dr. Aditya, Dr. Puneet, Dr. Rajiv Jain, and all our esteemed panelists and the participants. So the main problem in India is not the lack of infrastructure, it is the healthcare infrastructure is there. A lot of doctors, इतने सर पूरे दुनिया में नहीं होंगे जितने इंडिया में डॉक्टर्स हैं, but problem is our population. Our population is the problem. That is the reason why we are not getting proper vaccination. That is the reason why we are not getting proper treatment, because when this number surges, the infrastructure is overwhelmed. जो चीज जिसको जरूरत है वो नहीं मिलती सर. जो माइल्ड केसेस हैं वो जाकर हॉस्पिटल में एडमिट हो जाते हैं. कॉर्पोरेट हॉस्पिटल जिन लोगों के लिए फ्री है ट्रीटमेंट, they get beds, and rather than the people who really deserve these beds. Another thing, the oxygen shortage of oxygen concentrators, shortage of oxygen cylinders, they were all being purchased on the government price by the senior officials. They were kept at their residence, although they were not requiring that.
Hoarding.
That was hoarding of the
Yes.
by the senior people who are well placed in the government circles, or in the they have money to purchase all these. So that was the reason why this general public was not getting the oxygen concentrator or the oxygen. Same is with the medicines. So it is our culture in India which is causing all these problems, and the population which is causing problems. So it is becoming our utmost responsibility to protect ourselves, because 90% protection we can get from the masks and the proper ventilation, and having all those COVID appropriate behaviors. So I think, sir, it was a very lively discussion, and we will definitely go for more discussions as
Yes,
it evolves.
for
And
sure.
Thank
Yes,
you.
we would like to have you more
Great
often, sir.
insights.
We will take your time, please.
Right.
Anytime
Great
when
insights
you,
from Dr. Chawla. Sure.
Yeah.
anytime when you keep a topic of pulmonary medicine, you are welcome.
Thank you
yeah,
so much. We are
yeah.
honored. We are honored.
I would request
Okay,
Dr.
thank you all.
to moderate next session for you.
Yeah.
Maybe we
Thank
can
you all.
post-COVID syndrome, or how to
Yes.
go about with the post-COVID complication. That is also a very important issue right
No
now.
issue.
Absolutely, sir. Absolutely.
We'll keep
Thank you.
some time gap, and then we'll keep it, sir. Thank you very much.
Thank you.
Thank you,
Goodbye.
sir. Thank you. Thank you. Thank you very much.